Welcome everybody to tonight's presentation, Molecular Testing and the Implications for Adjuvant Therapy of Non-Small Cell Lung Cancer. Tonight's discussant is Dr. Charu Aggarwal, University of Pennsylvania, Leslie Heisler Professor of Lung Cancer Excellence. And Charu, with that, I'm going to turn it over to you.
Thank you, everyone. We'll make this interactive and case-based, and we'll talk about some new approvals, as well as why it's important for us to do molecular testing in early stage lung cancer. So targeted therapy and immunotherapy have meaningfully improved survival, at least in stage 4 lung cancer setting. We see this. You can see the immense progress we've made over a 20-year time point. In 2002, our median overall survival was only 8 months, and now we are experiencing 5-year overall survival of 32% with the use of immunotherapy. Adjuvant chemotherapy in the treatment setting for non-small cell lung cancer does provide an overall survival benefit. Historically, if we look across clinical trials, the DFS or the disease-free survival advantage has been a hazard ratio of 0.84 with an overall survival hazard ratio of about 0.9. In aggregate, that leads to a 4 to 5% overall improvement. Based on this overall survival improvement, we do use chemotherapy in the adjuvant setting. But as new drugs enter the market, we have to consider several other factors in the decision-making process. We have to look at the drug, the mechanism of action, safety profile, magnitude of clinical benefit, weigh that with the potential of harm, cost, as well as are there biomarkers to guide therapy. Give me 1 second. I'm just going to check with Dr. Kucharczuk. So there are 2 new approvals, or relatively recent approvals, that we should discuss. On December 18th in 2020, FDA approved adjuvant osimertinib. Again, this is for all resected non-small cell lung cancer patients with exon 19 or 21 mutations. And then last year, in October, FDA approved atezolizumab for the adjuvant therapy following resection and platinum-based chemotherapy in patients with greater than stage 2 lung cancer, but also with the caveat that they need to have a PD-L1 expression. If you look at the treatment paradigm in the NCCN guidelines for stage 2 and 3, the NCCN guidelines do recommend chemotherapy, or they recommend chemotherapy and atezolizumab or osimertinib. This data comes from the Empower 010 study, the schema of which is demonstrated here. Completely resected stage 1B to 3A non-small cell lung cancer went on to receive chemotherapy after surgical resection. And as you can see, they were randomized in a 1:1 fashion after chemotherapy to atezolizumab or best supportive care. The survival, patients were in survival follow-up, but the primary endpoint was disease-free survival, which was tested in a hierarchical setting, which is first, it was tested in the highest risk group, which is PD-L1 positive and stage 2 to 3A. And I will just say that this is the population that currently has the approval. And if you look at the results, the highest risk population, which is on the left, we saw a significant improvement in hazard ratio with a median disease-free survival, which is not evaluable with atezolizumab, but about 35.3 months with best supportive care. And then you can see that the disease-free survival hazard ratio is 0.6. If we look at the other populations, which is the all randomized patients and some intent to treat population, you can see that the hazard ratios are not that significant, suggesting that maybe atezolizumab doesn't have a benefit in the PD-L1 negative or the lower stage patients. When we looked at the subset analyses, it seemed to benefit most patients, but highest benefit seen in the PD-L1 greater than 50%. And overall survival data is still immature, as you can see on the far left for this treatment intent population. Hazard ratio for overall survival is 0.77, but again, very early. In summary, this is the first phase 3 trial to show an adjuvant benefit for use of immunotherapy. It was seen in more than 1%, but also the highest benefit was seen in PD-L1 greater than 50%. I am considering it and using it in patients without any actionable mutations. I think it's very important. That's why we are talking about testing. And then in smokers and in patients with high PD-L1, it does end up being a shared decision-making strategy. I will remind everyone that, coming to the cancer center for patients is not very easy. We have been using not just Q3 week, but sometimes Q4 week dosing of atezolizumab, which is actually available to us. Almost 2 years ago, we received results at the ASCO annual meeting from ADAURA, which is the use of adjuvant osimertinib. And as you can see, DFS in patients with stage 2 or 3A disease was significantly improved with a hazard ratio of 0.17. We'll say that this trial did not require that all patients get chemotherapy. So that's an important differentiator compared to Empower 010. Given the availability of targeted therapy as well as immunotherapy, it is important to test for molecular targets. At our institution, we have reflex pathways in place where we test for all actionable mutations in reflex fashion using our in-house gene sequencing panel. However, testing for early stage resected non-small cell lung cancer may not occur uniformly, mainly because there is a 14-day rule where resected specimens cannot be automatically sent for testing. Medical oncologists do ensure completeness in stage 4 patients. However, not all patients with early stage lung cancer may be seen by MedOnc. So I know we are changing this, and Dr. Kucharczuk, who's joined us, John, will tell us a little bit more about how his practice has evolved over the last year or so with these approvals. This is just a guidance that we published last year in lung cancer, recommending how tumor tissues and biopsies should be handled for testing. If we have a patient who has clinically stage 1 to 3 non-squamous non-small cell lung cancer, if a biopsy is available, we usually recommend reflexive testing of biopsy, molecular testing. However, if there's no biopsy available, these boxes of the blue recommend that for the resected tumor, testing would still be performed. But having said that, now we have another option which makes these things very challenging, which is on one hand, we have adjuvant immunotherapy, which I just discussed with you, where your patients undergo surgery, chemo for 4 cycles, and atezolizumab for 1 year. But now we have approval from Checkmate 816, which is a study of neoadjuvant chemoimmunotherapy, where patients received 3 cycles of chemo and nivo and then went on to surgery. Here is the schema. And as you can see, 358 patients randomized. And then both arms underwent surgery with an option of receiving adjuvant RT. And as you can see, median endpoint of event-free survival was improved significantly in patients that received neoadjuvant nivo plus chemo, with a median EFS of 31.6 months with a hazard ratio of 0.63. A couple of points I would like to make about this is that stage 3A patients tended to have the highest improvement in median EFS. You can see hazard ratio 0.54, meaning the more significant advantage. And then if you look at PD-L1 greater than equal to 50%, again, the hazard ratio is 0.24. I will point out that these numbers are small. These are subset analyses. These are not pre-specified. But I think these are important for us to enact in clinical practice. They give us signals. We know that immunotherapy tends to work better in patients with higher PD-L1 expression. So we are using this as a strategy for patients that have resectable disease, but may have stage 3 or high PD-L1 expression. Overall survival is immature at this point in time, but you can see that there is a trend towards improvement with a hazard ratio of 0.57 with the use of this approach. Many oncologists actually prefer this approach already because it allows to abbreviate the number of chemotherapy as well as abbreviate the number of immunotherapy cycles that are used. So in summary, Checkmate 816 neoadjuvant Nivo plus chemo showed an improvement in EFS, which is event-free survival versus chemotherapy. I won't read all of the bullet points because we've just discussed this, but I do want to highlight this box, which tells us that this was approved just before ASCO and actually just before AACR in March of 2022. Again, for anybody in the resectable setting, irrespective of histology, for patients with non-squamous histology, they should be EGFR negative and ALK wild type. So with that, I'll stop. And before we do cases, I would invite John to tell us about how his practice has evolved and what he thinks about this data.
Well, thanks, Charu. That was a great summary, as always. I think my message for you today, and I'm hopefully a lot of you already feel this way, is this has really become a partnership between the patient, the surgeon, and the medical oncologist. And I'd also say we include the radiation therapist. And I'll tell you, it's interesting. We've seen a number of patients with very early stage disease referred in from other institutions who, based on the FDA approval, wanted to give neoadjuvant immunotherapy. And we thought they were more appropriate to go directly to surgery based on our understanding of the data. So just because it's FDA approved for the indication does not necessarily mean that it's in the patient's best interest as far as event-free survival is concerned. We've kind of created a little conundrum, and you may want to speak to this, Charu, in 3A disease. Institutionally, we were always pretty aggressive for appropriate patients for trimodality therapy and going down the route of preoperative chemo and radiation therapy followed by surgery. And in this newer algorithm, it's really preoperative immunotherapy followed by surgery. So we've kind of left out the radiation arm. And Charu, I don't know, you can't really parse out what the value of that is. I don't know if there's a plan to do that in a head-to-head comparison study or not. As a surgeon, I'm quite interested because some of the initial trials of operating on patients after immunotherapy, there has been a higher conversion rate to more aggressive surgery because of the inflammation and scarring and things. But frankly, we find that as well when we give patients chemoradiotherapy. So it will be very interesting to kind of see how that pans out in the future. But I do think in the current era, frankly, I can't keep track of the updates and how quickly they come. And my practice is pretty much limited to lung and esophageal cancer. So I've really adopted the strategy of having all my patients seen and evaluated by medical oncology, oftentimes preoperatively and almost mandatorily postoperatively. I do still have some early stage patients that, will elect to come back to me for long-term follow-up. But in general, a lot of that has also been passed over to the surgical, not the surgical, but the medical oncologists who specialize in lung cancer and the general medical oncologist as well. And Charu, I don't know if you want to comment on the 3A. That's a very interesting and particularly difficult group for us. And I think that we haven't yet decided if chemoradiotherapy followed by surgery or alternatives to that with immunotherapy up front is going to be the answer.
Yeah, exactly, John. You hit the nail on the head. I think our most difficult and challenging discussions at Tumor Board revolve around management of stage 3A. We have a group of very dedicated thoracic oncologists who have an interest in also proton therapy. So like John mentioned, we were using concurrent chemoradiation, potentially utilizing proton therapy as a neoadjuvant approach, really isolating this approach to patients who could receive a lobectomy, not really utilizing it for patients that required a pneumonectomy, because we would declare those as potential unresectable or potential chemorads candidates alone, or go for upfront pneumonectomy. But I think those patients that we thought could be lobectomy candidates but had N2 disease, we were adopting the strategy of concurrent chemorads with a proton-based approach, and then sort of going on to surgery after about 50 gray of radiation. We haven't actually really incorporated radiation therapy in the setting of this approval with Checkmate 816. Some of our radiation oncologists think that it's still important to incorporate radiation at the back end, especially in the setting of residual N2 disease or if there's a positive margin. On the Checkmate 816 trial, RT was optional, although at this point in time, we don't know what the effect of that additional radiation therapy was on that subgroup of patients. To my knowledge, trial is comparing neoadjuvant chemoradiation, comparing it to neoadjuvant chemoimmunotherapy is not being done right now. If it was, it would need to be a cooperative group effort. I don't think an industry-sponsored trial would sponsor that kind of a trial. This is a 69-year-old male who presented with cough, left upper lobe mass, prevascular adenopathy, underwent a staging PET and MRI of the brain, which was unremarkable, but did confirm had PT2N2 disease. Biopsy revealed poorly differentiated adenocarcinoma, underwent, adequate PFTs for a left upper lobectomy. PDL1 of 80% and KRAS G12C mutant. What is the most appropriate treatment? Again, I think this is a clinical staging of N2 disease. I don't know if we have details about mediastinal staging or other features of this prevascular lymphadenopathy. Is this resectable? Is this not? I'll let John chime in.
Yeah, so these are kind of a subset of 3A patients. So yeah, I think no matter what, this patient needs invasive mediastinal staging. And part of it surgically, we want to try to determine, although we group the 3As together, it actually is a very diverse category. And so I want to know if the mediastinal nodes at 4L or 2L or 7 are positive. I obviously want to make sure he doesn't have contralateral disease, but that's particularly what I'm interested in. The prevascular nodes out in the AP window, those are, you can't really biopsy them through most standard mediastinoscopy procedures, and you really can't get there with endobronchial ultrasound because you can't make the turn. So then you're left with making a decision. If the mediastinal proper is negative and it's a left upper lobectomy, you're either going to have to presume that those AP windows are positive, or if it's very important and you're going to change your strategy to a preoperative treatment strategy followed by surgery, then you could biopsy those nodes easily with a video procedure. And we used to do Chamberlain's, but now you would just do a quick little left video procedure and biopsy them. If the N2 nodes are biopsy proven as negative, then this patient should just undergo a left upper lobectomy, and you'll sort out whether or not they need postoperative treatment. If the prevascular and AP window nodes are positive, it becomes a whole lot more interesting, because in the current area, you'd have kind of 3 options. You could justify operating on the up front and then treating them on the back end with, usually, if the nodes, AP window nodes are positive, we'd usually give them chemotherapy followed by sequential radiation. Or the other alternatives are, what's their PD-L1 status? 80% PD-1 status. So you could make the argument that this is, if you prove it, 3A disease, and they fall very nicely into the category who would benefit from preoperative chemo and IO followed by surgical resection. And the third option is that you could give them chemo and radiation followed by surgical resection, as long as you were pretty certain you weren't going to do a pneumonectomy, although even a left pneumonectomy is actually doable. It's the rights after chemo and radiation that we really worry about. So this patient has lots of options, but I think number one, I'm glad the MRI was negative. Number two, they need more than just a biopsy. They need invasive mediastinal nodal staging. And depending on your institutional kind of direction, you're going to have to decide, are you going to count the AP windows as true stage 3 disease, or are you going to count them 3A disease, or are you going to count them, we call them like 3.5. They're not quite there, which is based on very, very old information in the pre-chemotherapy era that suggests that people with AP window nodal disease only do better surgery alone than patients with mediastinal proper nodal involvement. So complicated patient. I think in this patient, I'd have to see is what his actual pulmonary function tests and performance statuses are. But I think in the current era, I would probably favor EBUS or mediastinoscopy. And if that's negative, I'd favor sampling those N2 nodes. And if they were positive, I think in an appropriate selected candidate, I think this may be the patient who might benefit the most from preoperative IO followed by surgery. So I don't know. What does everybody
I
else
think this
think?
is the kind of patient where preoperative chemo IO makes most sense. The
You got a
highest
high
stage patient,
PD-L1, you got, right.
high PD-L1, you have KRAS mutation. We know that IO works well in patients with KRAS mutation. And I think if this patient were to get a PAT CR or is one of the 24% that gets the PAT CR, then that approach has been well worth it. I think it also minimizes the toxicity, limits the number of chemotherapy cycles. You give chemo, also limits the number of immunotherapy cycles. So I think if feasible, would try to do neoadjuvant chemo IO in this setting. But if not, I think also using adjuvant atezolizumab is a very reasonable approach.
I'm curious,
case,
in
what'd you do?
patients where you see them early enough and get to look at them from a multidisciplinary perspective, how are you deciding which patients you recommend adjuvant IO versus neoadjuvant IO?
Yeah, so I think highest stage, highest PD-L1, complicated would probably be candidates for neoadjuvant chemo IO. I think you've seen sort of our thought process in somebody with a stage 2A node negative patient. We are saying not really chemo IO, maybe we'll come in with adjuvant therapy. But for somebody like this who has prevascular lymph node involvement and high likelihood of multi-station N2 disease, I think we're saying maybe chemo IO in the neoadjuvant setting.
Yeah, I think the key point of discussion is you have to prove it so you know what category you fall into. And I can tell you there are a number of times when we downstage patients by doing appropriate mediastinal and AP window staging, and that changes things a lot. And we can sort that out on frozen section because we have dedicated pulmonary pathologists. So I can, if everything's negative, I can do a lobectomy in the same setting. And if things are positive, I can stop, we can treat them and come back. And if it's done without much disruption around the hilum through a video procedure, it really is not going to affect a resection at a later date. So this is a great case. I wish it were mine.
Dr. Aggarwal, this is Jay Manikim. I think you touched upon if the patient happens to not have CR, and it becomes a data but with such high PD-L1, would you be tempted to give them adjuvant teaser? What would you actually do in clinic with this patient if they didn't have CR?
So if the patient had already undergone surgery, is that the question?
Correct, yes.
Yeah, so if the patient had already undergone surgery, I would talk to them about adjuvant chemotherapy. I would definitely discuss adjuvant rate or sequential sequential port or postoperative radiation therapy because of the presence of N2 disease, and I would absolutely use atezolizumab here.
I'm sorry, let me rephrase. After undergoing neoadjuvant IO, as you discussed, is probably better or makes sense as candidates, but the patient happens to be not in the 24% which you had CR, happens to not you had CR. Would you be still tempted to use adjuvant IO just based on the high PD-L expression and also considering the high relapse risk these patients anyway? Yeah,
what a great question. I don't know if we have the data yet. Would I be tempted to? Yes. Would I get the approval? I don't know. If I would get insurance approval, I don't know. I think I would look at smoking history. I would look at TMB. I mean, I'm just grasping at straws to see if I can find some predictors of a potential IO response. But I will say that if we are seeing lack of a PAT CR after 3 cycles of chemo IO, the likelihood of them responding to IO in the additional IO in the adjuvant setting is pretty low. So hypothetically, it doesn't make sense, but maybe I would be tempted to just clinically trying to do best for our patients.
Okay, excellent. Does anybody else have any questions they'd like to throw out? Okay. Well, with that, I'll thank everybody for taking some time out of their evening, and I wish everybody a pleasant night. Dr. Aggarwal and Kucharczuk, thanks so much for your time. And again, everybody have a nice night.
Thank you
Thank you
so
so
much.
much. Thank you. It was
Thank
a
you.
great
Thanks very much.
All right, bye.
Thank you. Great discussion.
Thank you. Bye-bye.